Welcome, everyone. My name is Heather Saffel. I'll be moderating. I am on our online fellow education subcommittee, and today we have Dr. Jim Moeller speaking on compartment syndrome, and he is actually one of the co-chairs of our subcommittee. We're really fortunate to have him leading us, and then he's very into education, a great mentor, so I'm excited to have him lecture all of us today. But he is currently the fellowship director of sports medicine at Henry Ford Health System. He's also the team physician at Wayne State University, and he's previously worked with several of the Olympic teams. And I forgot to say where I'm coming from. I was a fellow at Emory last year, and I'm currently on faculty at the Notre Dame Sports Fellowship in Indiana. So just a few things to talk about before we get started. Little lag. Okay, so again, this is our National Fellow Online Lecture Series sponsored by the Education and Fellowship Committees. It's an adjunct to your individual programs education. We have a lot of AMSSM members that experience giving these presentations, including Dr. Moeller, and it's to help assist you with your CAQ exam preparation as well. You're already muted when you come in. Please submit questions that you have in the chat function at any point in this lecture, and then we'll ask them at the end of the lecture. And please complete the evaluation. It's very helpful for us going forward to make this better and keep it going. So without further ado, I will go ahead and let Jim get going.
Thank you, Heather. Appreciate it. I appreciate all the hard work you do on the committee as well. It's a great honor to serve as a co-chair of this committee, and hopefully you've all found it to be helpful to your education. And again, it is an adjunct. We're not trying to take the place of the education that you receive at your individual programs, but sometimes it's nice to hear a new point of view on things. I hope everybody can see my screen. I've been looking at my screen the whole time. So my screen should be the shared one. You should see the introduction slide, compartment syndrome. Heather's already introduced me. So what I'm going to do, first of all, I want to apologize in that I have two screens going right now because I have notes on one screen that to help me get through some of the research components of the talk today, and then the screen that you see. And so if I'm looking up and down, that's the reason why. So I am going to try to toggle between two different screens throughout the course of the talk. So if I look like I'm not paying attention to you by looking at the screen directly, I apologize for that, but that's not the intent. Just some housekeeping. I don't have any financial or other conflicts of interest to disclose regarding this presentation. We want to jump in and talk about our goals and objectives of the talk, and we're going to define compartment syndrome. That's going to be a pretty simple single slide endeavor. We want to talk about the pathophysiology, review pertinent anatomy of different areas of the body where you might be thinking about compartment syndrome or need to test for compartment syndrome. And then we're going to review history, physical exam, discuss the diagnostic workup, and talk about different treatment options. And when we get into that, it may be a little bit, have a sense of a little bit of disjointedness for you, because I'm going to approach it the way I approach a patient with exertional compartment syndrome, especially when we talk about that part of compartment syndrome, because I do it a little differently than some folks do, where I actually maybe don't test as early as some other folks. And I will certainly let you know when it's my feeling and it's not based on particular science, but specifically when you go through the workup, there is no scientific best path to follow in that regard as well. So, but I'll be sure to mention when I'm talking about my specific approach to things. So to get started, I want to start with a CAQ question. This actually appeared on a CAQ back several years ago. A 25-year-old soccer athlete presents to your office for further evaluation of bilateral lower extremity pain associated with numbness of the first web space of the foot. The onset of symptoms typically begins after running for 10 minutes and ceases immediately after rest. Which of the following describes the pathophysiology? A, an abnormal increase in muscle compartment pressure interferes with tissue circulation, causing temporary ischemia and neurologic deficits. B, during exercise, muscles are perfused, but neurologic structures are compressed. C, compartment pressure is increased due to hyperperfusion. Or D, improved muscle blood flow during exercise results in ischemic pain and impaired muscle function. Now, I don't know if Andy, were you able to put a poll together for this? If not, just think about the answer that you think is probably the most appropriate here. And as we talk, we will get to the appropriate answer for you. But we're going to, there we go. So if you guys just go ahead and submit your answer, that'd be great. That should pop up for us in just a second here. Now, I don't see the result myself, but I'm sure Andy can get that up for us. The answer is A, that an abnormal increase in muscle compartment pressure interferes with tissue circulation. Excellent. Causing temporary ischemia and neurologic deficits. And we'll talk about why the other ones are not the answer here forthcoming. But when we talk about compartment syndrome, it's a painful condition that occurs when pressure within the intramuscular compartment or compartments elevate to a potentially dangerous level. And it can happen in numerous muscle compartments. It can be both acute and chronic in nature. And so certainly the presentation is different for an acute versus a chronic, or what people call chronic exertional compartment syndrome. You know, people tend to come in very, very soon with the acute onset, and maybe due to a different reason altogether. Where the chronic, it may take them a long, long time to come in, and it may take a long time to make a determination as to what the actual diagnosis of their pain is as well. But we'll talk about both of these things as we go. Acute is usually after trauma, and it can be a medical and surgical emergency, where the chronic is a non-emergent problem. The pathophysiology is that you get elevated venous pressure, which leads to a decreased arteriovenous pressure gradient, therefore decreasing the blood flow to the exercising musculature. So it's not a hyperperfusion problem, it's a hypoperfusion problem. The pressure causes vascular collapse and pressure on nerve tissue, and then that eventually leads to pain. The common locations where we see compartment syndrome, we all think about the lower leg as the compartment that we most commonly see it. And it is, when you talk about chronic exertional compartment, easily the number one body area where you find this, with the anterior compartment being the most commonly involved compartment, followed by the lateral compartment. We'll talk about this in the anatomy section coming up shortly. But you can see this in the forearm, in the thigh. And frankly, compartment syndrome can occur in any muscle group that is surrounded by fascia. So the hand, the foot, the buttock, the shoulder, paraspinal musculature, all of these areas are areas where potentially you could develop a compartment syndrome. And again, we're going to specifically address some of the areas here anatomically in just a moment. So we'll look at the forearm first, and then the thigh, and then we'll get to the lower leg, because we'll spend most of our time talking about the lower leg when we're discussing the chronic exertional compartment syndrome situation. So a classic Netter drawing showing cross sections of the forearm at different levels. And in the forearm, there are 4 compartments: the dorsal compartment, the volar compartment, which is divided into a superficial and a deep compartment, and then a lateral compartment. The common sports that you might see compartment syndrome, exertional compartment syndrome especially, would be things where the athlete is using the upper extremity as a weight-bearing tool. So they're kind of using their forearm like a runner uses their lower leg. So gymnastics, cheerleading, which includes a great deal of gymnastics skills, are areas where you'll see this. I've only scheduled, in 25 years, I've only scheduled 4 patients for an exertional compartment syndrome test of the forearm, and none of them showed up for the testing, interestingly enough. And so it's a very unusual thing that I've done over time with regards to looking for this. But again, those would be the sports that you see it most commonly in. Here's just a larger cross-section drawing of the different compartments. And if you look here in green, this is the lateral compartment, or the mobile wad, with the brachioradialis, the extensor carpi radialis, brevis, and longus. The radial artery and nerve runs in this area as well. The next compartment is going to be the superficial volar compartment, which is the most commonly affected forearm compartment, with the flexor carpi ulnaris, flexor carpi radialis, flexor digitorum sublimis, palmaris longus, The ulnar nerve is in this compartment as well, which you can see. I think my arrow should show up for you right here. And so if you're going to test the deep volar, you want to hug close to the ulna so you avoid the neurologic structure. When we get then into the deep volar compartment, you have the flexor digitorum profundus, superficialis, and flexor pollicis longus, and then the dorsal compartment, which is the extensor group with the aconius muscle, and so on. And so that's the anatomy in the 4 different compartments of the forearm. Let me catch up on my other notebook here as well. When we get into the thigh, there are 3 compartments. This is actually a patient of mine at time of surgery for a compartment syndrome of the thigh. But there are 3 primary compartments: the anterior, medial, and posterior compartments, and this is fairly easy to remember. Again, we have a classic Netter drawing showing cross sections of the thigh at different levels. And if we move on into a little more focused area, again, in drawing for representation, the anterior portion is going to be your knee extensors, so your quadricep group and sartorius. The posterior compartment is going to be your flexors, so it's going to be your bicep femoris, long and short head, semimembranosus and semitendinosus. And then the medial compartment is going to be your adductor groups, your gracilis, adductor magnus brevis, and longus as well. And so again, these are the 3 compartments of the thigh. In my experience, I've only actually ever tested the anterior compartment of the thigh based on the clinical findings of the patients that I had. And some of them were acute. Some of them were what I would consider to be subacute with a flare. I've never done a chronic exertional compartment test on a thigh. But again, for the acute compartment syndrome, it is not an unusual thing to have to test. If we move on to the lower leg, again, this is the area where you'll be thinking about it the most when you're talking about chronic exertional compartment syndromes. And if you do the testing as you get into practice, this is the area that you'll be testing the most. It is divided into 4 compartments: anterior, lateral, deep posterior, and superficial posterior. There are some studies that suggest that there may be a 5th compartment in some people in the deep area, where they have a fascial band that extends from the posterior aspect of the tibia and maybe divides the deep posterior compartment into 2 separate compartments. It was found as an anomaly when a patient was treated with fasciotomy for chronic exertional compartment syndrome, then continued to have issues after the surgery. When they went back in, they explored and they found this fascial band creating a 5th compartment in this person. And then they did some cadaver studies and found that it does happen from time to time. I don't have the exact numbers for you, but in general, we think of 4 compartments. That would be the thing to remember when we're talking about being tested and looking at CAQs and things of that nature. The anterior compartment contains the tibialis anterior, extensor hallucis longus, extensor digitorum longus, and peroneus tertius, with the deep perineal nerve. So when you saw on that question, the first web space having numbness, you're talking about the deep perineal nerve, and so you're talking potentially about the anterior compartment in that patient. The lateral compartment has the perineal muscles and the superficial perineal nerve, which is going to give sensation more across the dorsum of the foot. It's a little bit odd to me because the lateral compartment contains the nerve that gives you sensation of the skin over the anterior compartment. But again, it's just the anatomy that you need to recall. We get to the deep posterior compartment. You have the tibialis posterior, flexor hallucis longus, flexor digitorum longus, Tom, Dick, and Harry, popliteus, and then the tibial nerve and posterior tibial vessels, and then the superficial posterior being the gastroc soleus and plantaris, or the calf musculature, and the sural nerve runs in that area. If you look at cross-sectional drawing of the fascial compartments without the musculature, this would be what it would look like, and we'll just superimpose the musculature over top of that at this point. And then what we're going to see here is your anterior compartment highlighted in blue with your tibialis anterior and your extensor musculature, as we discussed. In red here, this is your lateral compartment. And then you have your deep posterior compartment, and then again, in green, the calf musculature with the gastrocs and soleus and plantaris in the superficial posterior compartment. So that's enough of an anatomy review for you. But again, it's important to know, especially if you're going to be sticking needles into people to test for compartment pressure, because you have to know, what group you're in, how to access that group most successfully, and how to avoid neurovascular structures as well. So let's talk a little bit about different types of compartment syndrome. As I mentioned before, there are two types that we talk about: the acute compartment syndrome and a chronic exertional compartment syndrome. We're going to start by talking about acute compartment syndrome. This is another patient of mine who had thigh compartment syndrome. They also had an infection. We'll talk about why in just a moment. Common causes of acute compartment syndrome include fracture, which is probably the most common cause, a muscle contusion. I've seen at least probably 8 cases, maybe up to 10 cases of thigh compartment syndrome acutely due to muscle contusion, reestablishment of blood flow after blocked circulation, a crush injury, anabolic steroid use, which in the photo you saw just previously, that was the case. The person was injecting anabolic steroids for bodybuilding and developed an infection in the anterior thigh compartment, which created an acute compartment syndrome. And then constricting bandages and casts. So be careful if you're doing fracture care and you're casting people, how you put the cast on. The underwrapping can create pressure points. Putting the cast on too tightly, especially in someone who may be swelling within the cast, can also lead to acute compartment syndrome. Now, classically, when we talk about acute compartment syndrome, you talk about the 5 Ps. And so you probably remember the 5 Ps: pain, pallor, paresthesias, pulselessness, and paralysis. In a lot of cases, you're not going to get all 5. In fact, in most cases, you won't get all 5. Pain may be the only P that you see when you're talking to someone with acute compartment syndrome. Paresthesias and pallor, not terribly uncommon. Pulselessness, I don't know that I've ever had anybody with an acute compartment syndrome in a sports medicine setting with pulselessness, and paralysis, again, is a very late finding, and the person is in pretty high risk at that point. But those are the classic symptoms that you're looking for. On examination, the involved compartment will be tender to palpation and be very firm, so that tense musculature, almost a wood-like feeling. Sometimes as you press and roll, when you get used to the tissue tension, muscle tissue that's relaxed, you kind of press and roll out under your hand quite nicely. And when you get to a compartment that has significant involvement, it'll be like rolling over a log. You can't press down into it. They call it woody tenseness. If you stretch that compartment, that will often cause pain for the patient. And again, that's a very classic finding. I've very rarely seen patients with acute compartment syndrome who don't have pain with passive stretch. Weakness is typically due to pain while you're trying to test them, so they just can't stand it, and so they can't really show you strength. Decreased sensation is certainly not uncommon. Paralysis and pallor, like we talked about, would be a very late finding and is not typical in the patients, certainly that I've seen with acute compartment syndrome. So testing to try to figure out if the person actually has it or not, you don't need to do compartment pressure testing to come to a diagnosis if someone meets the right history and the right physical exam findings, because we are talking about an emergent problem. Actually, it's not urgent, it's an emergent medical and surgical problem. And if you don't have access to compartment pressure measuring devices, you can make the presumptive diagnosis based on history and physical examination. However, if you do have those devices and you're going to use them to assist you in diagnostics, you have to know what numbers to look for. In acute compartment syndrome, you're looking for a difference between the diastolic blood pressure of the patient and the pressure of the compartment that's being measured. Normally, at rest, a muscle is going to be, at 10 or less millimeters of mercury. And so in an acute compartment syndrome situation, you want to check their diastolic blood pressure. And if the difference between that pressure and the compartment pressure is less than 30 millimeters of mercury, so if someone has a diastolic blood pressure of 80 and a compartment pressure of 60, that's a difference of 20, that's going to be diagnostic of compartment syndrome. Most recent patient I had with an acute compartment syndrome in his thigh had a diastolic pressure of 85. They're in pain, so it may be a little bit elevated from what their normal is, but he had a compartment pressure of 135. And so I got a surgeon on the line and got him over to the hospital immediately for evaluation and consideration of fasciotomy. And so obviously he was in the opposite direction of where you want to be. The treatment is surgical, opening the fascia to release the pressure. This is a photo of a high school football player that I took care of. This is not the surgical photo at the time he was open during his acute phase. I don't have a picture of that. The surgeon got in, rushed him in, got him opened up and didn't take a photo. So this is right before his skin was actually closed. But this young man decided he wanted to be a football kicker. And he had never kicked footballs before. So he got a couple bags of footballs from the coach and he went out to the football field one day and started kicking footballs. And for 4 hours, he kicked footballs, punts, kickoffs, field goals of different lengths. And he was really, really sore in the anterior lower leg by the end of it all. And he went to bed that night. He was quite sore and he woke up and he was even in more pain. And then at school, he actually fell coming down the stairs because he kind of lost control of the dexterity of his lower leg. And he came in with woody tenseness and swelling and pain on palpation and passive stretch. And he had a compartment pressure of about 120. And I sent him off and they opened him up. Now, they couldn't actually close him on that day because the tissues were so tense. So they packed him and did a loose closure. And then what you saw on the previous slide was when they took the packing out before they did the final closure on this young man, which is what you see here. And his outcome was excellent. But acute compartment syndrome, again, it is an emergency, and we need to make sure that we know our surgeons in town who perform fasciotomies for us so we can get our patients to them quickly to make sure that we get the best possible outcome for our patients with regards to the health of the muscle tissue of that involved area. So what we're going to do now is we're going to switch gears and we're going to move on to chronic exertional compartment syndrome, which is what you'll see more commonly in a sports medicine setting. Question is it chronic? Which it's not always the case. Some people present within weeks, certainly in less than 3 months of onset of pain. And the other question is it exertional? Because it's not always. Some folks will have elevated resting pressures. And so even though it's not at a level where you would make the diagnosis based on the diastolic minus compartment measurement that we talked about a moment ago, it still would be considered to be too high for resting pressure in an athlete. And so it may not be chronic, it may not be exertional, but again, in most cases, it tends to be both. It's most typically associated with the sporting activities that involve distance, some type of distance or continuous running. So a distance runner, like a cross-country runner, or somebody who runs, 5Ks, 10Ks and such. Soccer players, military recruits, we get a ton of information from the military on this. Our largest team in America and the sports medicine physicians do a phenomenal job with them and have put out a great deal of literature on compartment syndrome in military recruits. We'll talk about that more in just a moment. It tends to be more common in sedentary people who then go out and try to become active, but it can hit somebody who's been active for a long time as well. And that's always a question that I get is, why did it hit me now? And I don't really have a great answer for folks when they ask that question. Here's a study from the military that was published in 2013. It was a retrospective study of 4,100 cases of chronic exertional compartment syndrome over 5 years. Wow, that's a lot of experience with chronic exertional compartment syndrome. And what they found was that there was a slightly higher amount when you look at adjusted incidence rates in females than males, and slightly more in Caucasians than in other races. And so this is, again, what was found in the military. What they also found was that the junior enlisted had a higher adjusted incident rate, and then the Army, people who were in the Army had a higher rate than people in other branches of the military. And I'm not going to make any jokes about that. I'm sure if there are military people here, you guys have your nicknames for the other branches of the military and such. But again, this is what was found. And this was a retrospective study looking at all branches of the military with regards to chronic exertional compartment syndrome. Finally, when you look at the age of the patients who had this, and again, this had to be adjusted because the numbers are different. It was people over the age of 40 were more likely to have it 8.77 incident rate ratio. So the older the athlete, the greater the likelihood of developing exertional compartment syndrome. And again, this was a huge study looking over 5 years of data from all branches of the military. So when someone comes in to your office, they're going to have this atraumatic lower leg pain. It's worse with exercise, improved with rest. It may be described in a variety of ways. Aching, cramping, burning are possibilities. The timing with exercise is often predictable. It's hard to tell whether they're talking about periostitis, medial tibial stress syndrome, stress fracture, exertional compartment syndrome. There are a lot of different things that cause lower leg pain. You know, everybody comes in, they say, oh, I've got shin splints, and you don't really know what that means. I think that a lot of folks who retire from their running sports after years of chronic shin splints, many of them probably had exertional compartment syndrome, and they just never were diagnosed with it. Maybe that's because they went to people who don't think about it or don't know about it. If you don't think about it or know about it, you'll never make the diagnosis. There's an orthopedic surgeon in Kentucky, Mary Lloyd Ireland, who often makes the comment, she'll say something like, I've never seen it, but I'm sure it's seen me. And so I wanted to make sure I got that quote right. And so, you know, I'm sure that you've seen exertional compartment syndrome, but you just didn't know it yet. And so, again, hopefully after the discussion today, it's something that will come to mind. The interesting thing is that the timing is often predictable. A lot of folks who have shin splints or periostitis, they'll start to have pain early. That pain will actually start to go away as they continue to exercise, and they'll have this grace period during exercise. People with stress fractures, it builds up and then tends to stay high, but the pain can actually creep back earlier and earlier into their running activities as the stress fracture advances, where again, you often get this predictable timing with exertional compartment syndrome. A lot of times, though, it's a very vague, generalized description. It's hard to tell. Some people will get what's called a second day phenomenon, where if they do heavy exercise on consecutive days, the pain will actually start much earlier on the second day. And so that can throw things off a little bit too, with regards to predictability. They may describe some associated symptoms, numbness and weakness. They may describe a foot drop or some type of steppage gait. You want to watch them when they walk in, certainly. It's going to be bilateral in up to 75% of cases. You will read about fascial herniation and description of fascial herniation with chronic exertional compartment syndrome, and that it's quite a high correlation between the two. A visible herniation on clinical examination, I don't really find that to be the case in my experience. But again, at time of surgery, some of the surgical literature does discuss a very high correlation between fascial herniations and people with exertional compartment syndrome. Examination at rest may be totally normal. So again, it doesn't really help you make any decisions necessarily. It is important that you rule out other things. We talked about some of them already. Also things like DVT, lumbar radiculopathy, some type of vascular problem, nerve problem, even bone tumors. And so doing a thorough workup is certainly important. Because the exam may be normal at rest, it can be helpful if you have the ability to exercise the patient while they're at the office, and then do the exam afterwards. And you may get some of the clinical findings that we talked about in the acute compartment syndrome, with increased tenseness over the involved compartment, pain on palpation, passive stretching causing discomfort, weakness or at least painful muscle contraction of that compartment, and so on. We're going to move on to diagnostic testing at this point. And again, it's important to rule out other pathologies. These are three of my patients that I've seen in the last year. On the far left, the X-ray that you can see the periosteal changes and thickening here. Someone with a distal fibula stress fracture. I don't know how well that shows up on all of your screens, but that could be confused with a lateral compartment pain. And then in the center, a bone scan showing fusiform uptake in the mid to distal tibia, medially consistent with stress fracture, and then on the far right is an MRI showing marrow edema in the medial aspect of the proximal tibia, with the fracture line cutting into that area as well, being a grade 4 Frederickson stress fracture there. Now, so getting these tests is helpful to rule out other pathologies. It's not going to rule in compartment syndrome for you. An MRI is not going to tell you whether you have compartment syndrome. You need to do compartment pressure testing for that. And this is where I start to veer off of where some people may go when it comes to compartment pressure testing. So again, I want to give the disclaimer that what I'm going to talk about now is my approach to things. We will talk about testing. We will talk about treatments. But again, at this point, if I have someone who presents with a history that is certainly suspicious for chronic exertional compartment syndrome, a physical exam that is suspicious, a workup which has not shown any of the other problems that I'm looking for, such as, again, periosteitis, stress fracture, etc., and I'm thinking chronic exertional compartment syndrome, before I put a needle into their leg, I talk to them about treating them for compartment syndrome in a conservative way, because there are risks to doing the procedure. So instead of taking those risks, is it safer to just treat for the presumptive diagnosis first and see if it works? Because if it works, then we don't necessarily have to test. If it doesn't work, we can always test later, and we probably aren't putting them at any greater risk. So again, this is where I tend to veer off a little bit. So my recommendation is you consider treating them conservatively prior to doing the invasive testing, because there's very little risk to the conservative management, and there is risk to the testing itself. So again, if I have somebody who fits that picture and I'm thinking chronic exertional compartment syndrome, before I stick a needle in their leg, I talk to them about maybe just going ahead and treating for presumptive compartment syndrome. And that would include avoidance of pain-provoking activities, icing. Heat can also be helpful and be soothing. Non-steroidal anti-inflammatory medications, physical therapies, which can be done at home or in a formal PT setting with stretching, massage, strengthening. Maybe adding orthotics if they have some foot irregularities, and maybe talking to them about some gait alterations, which may be of benefit in a runner, especially if the anterior compartment is involved. Now, there is a systematic review that was published some time ago, back in 2016, and Dr. R. and Mederick Hall came up with this algorithm with regards to non-operative treatment of exertional compartment syndrome. So I'm going to let you memorize that real quick. But it talks about massage, it talks about gait alterations, it talks about chemodenervation with botulinum toxin and ultrasound-guided fascial fenestration as possible treatments prior to the thought of fasciotomy, the surgical treatment, which we will get to all of these things. And so what I like to do is I like to divide these even further into the non-invasive and the invasive, because botulinum toxin, you have to stick a needle in somebody, and when you fenestrate the fascia, you have to stick a needle in somebody as well. So again, if I'm going to start with a patient with treatment, especially before I know for sure whether they have it, I'm going on presumptive diagnosis, we're going to start with the very conservative non-invasive types of treatments. Looking at that systematic review, they reviewed several papers that fit the criteria for review and looked at several things. Only one study of 7 patients showed that massage of the compartment would increase time to pain with activity and decrease post-exertional pain, but was found certainly to be helpful. There's a lot more information, even though it still is not a high number of patients, on gait alterations, and this showed mixed results. Problem being that the study with the best outcomes were testing patients who didn't have compartment syndrome problems. They were taking healthy volunteers and testing their compartments pre and post exercise. And what they found was that toe running, so you're absorbing the force in your posterior compartments, would help reduce the anterior compartment pressures, as well as a negative heel rocker shoe like you see here. With a negative heel rocker shoe, the maximum pressure was significantly less when you compare it to conventional soles maximum pressure with the heel rocker being 36 millimeters of mercury, with conventional sole being nearly 60 millimeters of mercury in their tested patients in a couple of these studies. And then the mean pressure was also less, and those were statistically significant findings. And the reason being that when you're rocking onto the front of the shoe and the front of the shoe hits earlier, you don't have to fire your anterior compartment eccentrically to keep your foot from slapping to the ground. And so that's the physiology of why a heel rocker shoe like this may be of benefit. And again, if you're landing on your ball of your foot and absorbing the force in the posterior compartment, you don't heel strike with your foot wanting to slap down to the ground. I want to get my hand in there so you can see it slap down to the ground. And so to stop that slap, you have to fire in your anterior compartment eccentrically to hold the foot up and control that motion. And again, if you are running in a standard heel strike gait, you're going to have an increased likelihood of causing the eccentric load on the anterior compartment and increase the likelihood of exertional compartment syndrome. So anyway, those are a couple of changes that can be made very easily. Massaging of the compartments, stretching of the compartments, all of those things can be helpful. And if people do well, then we don't have to worry about testing them. But if they fail, or if the treatment fails them, is how I like to put it. I don't like to tell my patients that they failed treatment. I like to tell them that their treatment failed them. Then we're talking about testing folks. So let's get to another CAQ question. Which of the following confirms the diagnosis of chronic exertional compartment syndrome? A 1-minute post-exercise test of 28 millimeters. B, pre-exercise pressure of 19. C, I changed it to a 15-minute post-exercise pressure of 14. Or D, a 5-minute post-exercise pressure of 17 millimeters of mercury. So go ahead and submit your answers there. I'm going to submit mine too. I know the answer though. I wrote the question, so we'll see how everybody responded here in a minute. So if Andy can pop that that result up here for us in just a second, we'll go ahead and move on. The answer is B. It's a pre-exercise pressure of 19. And we'll go over the 1-minute, 5-minute, the 15-minute I added in because basically that's being back to at rest. And so you would use a 15-minute or a 20-minute post-exercise test as an at-rest test. So let's move on here and talk about compartment pressure testing. Because again, in my line of thinking, now I have somebody with a history that's consistent, a physical examination that's suspicious, a workup that didn't show some of the other more common things. And when we treated them for presumptive chronic exertional compartment syndrome with non-invasive conservative management, they didn't respond the way we wanted them to. Now it's important to get numbers because now we're talking about doing a more invasive type of treatment procedure for them. And now the numbers become extremely important. So the classic benchmark study that looked at compartment pressures to determine what level is normal and abnormal was done by Pietowicz and colleagues and published in 1990 in the Journal of Sports Medicine. And Pietowicz, what they did was they took a lot of people with who didn't have problems, but they just measured their compartments to find out what the mean pressure was in a very large group of people. And then they did statistical analysis to figure out 2 standard deviations above that mean and use that as a potential number for abnormal pressure. And they actually rounded that up even higher to a multiple of 5 to try to get an appropriate number to use as a baseline. And the reason they did that is they wanted to lower the risk of false positive testing. So they, again, went 2 standard deviations above the mean plus rounded up. And then again, that's been used for many, many years as kind of the criteria. Now, not everybody uses the same criteria. Some will still go with blood pressure difference to the compartment that's measured and such. But again, the most commonly quoted group is the Pietowicz numbers. I'm sorry, I'm getting, my 2 screens is getting me messed up a little bit. So anyway, with Pietowicz, the at-rest pressure, if it's over 15, so if you're 15 or less, you're normal. So if it's over 15, it's abnormal at rest. And then again, according to their studies and published data, at 1 minute post-exercise, it could be, you can do it immediately post-exercise, but the 1 minute post-test over 30 and the 5 minute test over 20. Now, what I'll have people do is I'll actually have them exercise at home before they come into the office for their compartment pressure test. And so when they drive in, they're actually going back to an at-rest situation. My thought being that if they've already kind of created an issue for themselves that day, I might increase what I call the first stick yield. So maybe I can just get them with an at-rest pressure that's elevated and more likely to find that. And I don't know if that's true or not, because I still put a lot of people on treadmills to run them for 10 minutes before I do their post-exercise testing. But regardless, these are the numbers that I use. I use the Pedowitz criteria. And once they have a positive test, I don't continue to test that compartment because once it's positive, it's positive. What you see on the left is an example of a handheld pressure monitor. There are others. You can even jerry rig your own using a 3-way stopcock valve and a manometer and a saline filled syringe. The first compartment pressure test I ever saw, the orthopedic surgeon actually created a pressure monitor right there in the training room. It was amazing. Oh, going the wrong way on my screen at home here. All right. So you have to consider risks when you're talking about sticking needles in people. There are several different kinds of indwelling monitoring you can do. One is a side port needle, which is the way that I use. You can use an indwelling catheter or a wick catheter for that, where you actually put the catheter inside the compartment and then tape the catheter to the side of the leg. So when they do their exercise, you can just hook it up to the Muller lock and get your pressure right away, as opposed to sticking them over and over again. But bleeding, infection, nerve injury, you can create an acute compartment syndrome. So you've got to be careful and you've got to know what you're doing. There are some non-invasive techniques, near-infrared spectroscopy, which is looking at oxygen saturation through how much of a continuous wavelength of light is collected over a certain distance. There's something called shear wave elastography, which is being looked at now, which is looking at muscle stiffness with ultrasound. The problem with this is it's fairly costly. It takes about 10 to 20 minutes to obtain a result on a single compartment, and the probe has to maintain direct contact the entire time. So it's difficult to do technically, but there are some non-invasive techniques that are being studied. And if you get that diagnosis and you have those numbers and conservative non-invasive management has failed, you do have some invasive treatments that you can try: botulinum toxin injection, fascial fenestration, and then finally fasciotomy. So here's a study on botulinum toxin injection that was performed in France and published in 2013. What they did was they took people who had a diagnosis of compartment syndrome. There were 25 anterior compartments in 16 patients and 17 lateral compartments in 12 patients that were found in this study. But you can see it took almost 60 months, an average of 40 months for people to come in or to be diagnosed. What they did was they ran them on a treadmill. I'm sorry, I don't know why we went that way. They ran them on a treadmill, and then they took their clinical data and measured their compartment pressures at 1 minute and 5 minutes after running. And then they injected them with botulinum toxin. 1 month after the injection, they went ahead and called them and got clinical data on these patients. And then at an average of 4.5 months or so, but up to 9 months after the initial treatment, they put them back on the treadmill and did the whole test over again. And here's what was found. When you look at the 1 minute test, compare before botulinum toxin to after botulinum toxin, there was a significant decrease in the 1 minute pressure, post-exercise pressure in the anterior compartment after the botulinum toxin was given. And that held true at the 5 minute pressure as well. And as you would expect, the 5 minute pressure in general is lower than the 1 minute pressure. When you look at the lateral compartment in these patients, the same findings took place, where patients did better after the botulinum toxin, and these were statistically significant findings. Also, there are other studies out there looking at botulinum toxin as a treatment, which have also shown benefit. There are a couple of examples here below, but I just, for the sake of time, only wanted to review one of the studies in more detail. The case of fenestration and what was used in the systematic review was based on a single case report using an 18-gauge needle to fenestrate the compartment of a 18-year-old female lacrosse player. And she had excellent results, full resolution of pain and return to full activities. Follow-up at 18 months showed that she remained pain-free, which is great. But again, it's only a single patient. And so this is something that obviously requires more study to try to determine whether fascial fenestration is a reasonable option. Anecdotally, patients of mine who have exertional compartment syndrome, and we're doing the testing, and sometimes you get to that really tough fascia and you pop through it and you get this high pressure. A lot of them will tell me that they had a sense of ease of the pressure and their discomfort in the days following the procedure. And that's only putting a single or up to 3 holes in the fascia, depending on how many times we had to test the compartment. So again, not enough to say that I would do this for patients, but certainly an interesting idea that I think requires more study. The gold standard for treatment is still considered to be fasciotomy. What you see here is a 2-incision technique that's typically used now in patients with chronic exertional compartment syndrome. They connect the fasciotomy below the skin surface. There are multiple studies that have shown its effectiveness. Here are several. The study by Packer looked at both patients who had anterior compartment alone as well as anterior with lateral compartment releases. The patients who had anterior compartment alone actually did better than the folks who had 2 compartments released with regards to resolution of their symptoms. The study that is by Shepsis also looked at patients with anterior compartment syndrome, because a lot of surgeons will say, geez, since I'm sitting right there at the lateral compartment, I'll release that too. But they also found that patients who had both compartments released, if they only had anterior positive numbers, the folks who had 2 compartments released didn't do as well as those who only had the anterior compartment released. So the take-home message was, if only the anterior compartment is involved, only release the anterior compartment. And then making sure that 90% of the fascia is open in length is important too. That was Hutchinson's group, but that was using a swine model. Here's some more science looking at fasciotomy and post-fasciotomy results. This was a little bit odd because it started with a visual analog scale, then went to a verbal reporting scale. Initially, what was found on the visual analog scale was those with the higher pressures had higher visual analog pain. And those post-fasciotomy, both in the anterior compartment and the posterior compartments that were studied in this group, did much better after the fasciotomy, as one would expect. Looking at the verbal reporting scale, the same findings took place, that people did much, much better with low pain afterwards, and no high pain patients in the post-surgical group. So again, pain reduction and increased activity level is reported very commonly. This is a speed skater that I used to take care of. You can see the bulge on the right side. So she has a scar and a bulge, but she doesn't have pain anymore. So she was pretty happy with that trade-off. Up to 80% will have significant improvement in return to sport, but 20% or so will have some type of recurrence of pain. Here's a study that looked at runners who had fasciotomy, and most of them were able to return to running activities, but there were about 16% that could not. Interestingly, of the group that could not return to activities, not all of them were complaining of discomfort with normal daily activities, but they may have had some symptoms when they ran, which kept them out of the running, so to speak. When you look at those who did return to their sport, you had a group of 67% of those that actually returned to full running, but a group also returned to other types of sports. So return to sport didn't necessarily mean return to running. But in that group that didn't return to running, a fair number of them still remained asymptomatic. So 24 of the 32 were asymptomatic after this and were satisfied with their procedure. So that's a pretty good number, but it's not 100%. It's not a guarantee. And when you look at time to return to sport, Here's a study out of the Ohio State University that looked at timing to return after anterior and lateral release versus a 4-compartment release. And you can see you're talking about 2.5 to 3.5 months for return to full sport. So it's not you get the surgery, the wounds heal in a couple of weeks and you're back to it. There is a time frame that has to take place before return to full sport is feasible. But again, fasciotomy remains the gold standard treatment for patients who don't respond to conservative management for chronic exertional compartment syndrome. So again, I took you through the way I look at it, the way I take people through it. Again, I don't do the testing right away necessarily because there is risk involved with the testing. And since there's no risk with non-invasive conservative management, I try that first if I have high suspicion. And if that fails the patient, then I get into getting numbers so we can get into invasive types of treatments. And we're just a little bit over 45 minutes now. So I quickly just want to recap for you some things. First, acute compartment syndrome is a medical and surgical emergency. So if you have someone with an acute compartment syndrome, you need to get them into appropriate hands for discussion of fasciotomy. Though most common in the lower legs, chronic exertional compartment syndrome can happen in many areas. And think of upper extremity, forearm in your gymnasts and cheerleaders. Acute compartment syndrome can happen in any compartment that has a fascia. And so be prepared for making that diagnosis in the appropriate clinical setting. Remember though that common things are common, and certainly there are things in certain body areas that are much more common than having a compartment syndrome develop. And so you want to make sure you're doing a good job at looking at the patient completely and doing a full workup and not just jumping to a specific conclusion when you're talking about chronic exertional compartment syndrome. On the flip side, patients who have acute compartment syndrome, you don't have to have the numbers to make the diagnosis always. Consider your conservative management options, non-invasive type before doing compartment testing. That's my feeling. Again, it's not everyone's feeling. And then again, surgery is needed for most patients with lower leg compartment pressure syndrome. But botulinum toxin showing some real promise. And we have to do more study on the fascial fenestration technique to see if that works for us as well. So with that, I appreciate everybody's attention. And hopefully I didn't go too far over. I think I was a few minutes, about 4 minutes over there. So I'm going to stop my screen share now, I think.
Thanks for the great lecture, Jim.
I hope that was appropriate and what you guys were all looking for.
I thought it was great, and that's okay. You went over. Everyone, thanks for tuning in. We had quite a big showing today, up to about 70, which is one of our largest. Please fill out the survey before you sign off if you can to help us, whatever we did well, whatever we can improve on. We'd appreciate it. And we did have quite a few comments and questions, so I'll start with some of the questions. And this is specifically for fellows, so I understand maybe some fellows were asking the question and possibly attendings answering, but I'll still ask those to Jim to get his expertise. So one of the questions was, if the resting test is positive, do you have them exercise and then retest?
The way I do it is this: if they have a positive resting test, we have the diagnosis at rest. And the way I put it to patients is, look, if you have a positive strep test, I'm not going to retest you for strep to see if you have strep 5 minutes later. I'm going to take the sensitivity and specificity of the test I did to make that determination. And so let's say somebody has normal resting pressures, and then at 1 minute they have a positive pressure in the anterior compartment, but the rest are normal. I won't retest the anterior compartment at 5, but I'll retest all the rest at 5. Because I want to complete the test to make sure, because some people will still continue to creep up. Usually you get that rise and then it quickly tapers off. But some people at 5 minutes will actually continue to creep up. And remember, there's a 10 millimeter difference between the 1 minute and 5 minute tests. So it's 30 and 20 are your cutoffs. And so if you have someone who's at 25 millimeters mercury at 1 minute, and they don't come down much over that 5 minute rest period, and they stay above 20, they're going to be positive. So I carry out the test until I get a positive result or until I complete the test. That's how I approach it. And patients always have the ability to stop the test at any point if they desire. If they're too uncomfortable, if they just want to be done with it, If I have somebody who has a pressure that's 14 at 1 minute, they say, geez, I'm already under the 5-minute mark. I don't want you to test that one anymore. And they have the option to do that because I can't test them without their consent at any point of the procedure.
Great. So on to the next question. When performing compartment testing, do you feel that ultrasound guidance is needed to confirm placement of the needle and the correct location / compartment?
I do not use ultrasound to guide my compartment pressure testing. If you have a really fleshy patient, you may wish to use that to make sure that you've gotten through the subcutaneous layer far enough. Your needles are usually around 3 inches long, and I'm sorry, they're around two and a half inches long, but you want to put them to a depth of at least 15 millimeters or deeper. A lot of times you'll feel as you hit the fascia, it's a tougher tissue, and then you have to kind of lean in to get it to pop through. But I do not use ultrasound guidance to do mine. I certainly wouldn't fault anybody if they decided they were going to use that for theirs. Remember too, you have to have the body part at level with the heart as you do these. So you have to have a patient, if you're doing the lower leg, supine on the table. If you're doing the upper extremity, you have to have it resting on the table at the level of the heart as well, because if their arm is hanging down, it will increase the pressure falsely. If the extremity is elevated in relationship to the heart, it'll decrease the pressure falsely.
Okay, great. Next question. So obviously we know you would want to compartment test the symptomatic leg, but do you have to compare that to the asymptomatic leg by testing both?
Based on the studies that have been done that looked at normal pressures and abnormal pressures and symptoms in symptomatic and non-symptomatic patients, I do not use the patient's asymptomatic leg as their own control. So I go based on the science that has come before me and use that to the best that I understand it. But I feel that the risk of the test in a asymptomatic leg, if you're not doing it for research purposes, is not worth taking. And so again, I use the Pedowitz criteria, as I mentioned, and I do not use the patient's asymptomatic leg for their for comparison's sake.
Okay. And closely related on to the next question is that how do you navigate the timing of, let's say both legs are symptomatic and doing the Pedowitz criteria, getting all of that testing in one sitting? How long is your visit, or do you ever have them come back, or what are your thoughts on fitting it all in?
Yeah, that's a real difficult thing sometimes, because you can do the at rest pressures easily because they're all at rest, and so you don't have you're not under a time crunch with that. And patients who have bilateral symptoms, I plan to test them on 2 different visits for a couple of reasons. One, it's very difficult to get the timing right, and to do the timing correctly, even if you're testing 4 compartments in a single leg, it's hard to get the timing right. But if I have to test their compartments in one leg and then put them on a treadmill and then bring them back and test them again until that test is finished, and then put them on a treadmill again and bring them back, it's very difficult to do. And if they have a complication from the procedure, and I did both legs and they potentially have a complication on both sides, and thankfully we don't run into complications very often, now I've set them up to have problems on both sides. And so what I do is I tell people, look, we're going to test one leg at a time. What I want you to do is I want you to pick your worst leg, and let's do that one first. Because if your worst leg comes back that it's not compartment syndrome, you may decide to defer to do the other one. And so if their opening pressures are all abnormal on the first leg, they'll say, hey, look, we're done with this leg already. Do you want to do the other one? But I can't do 2 sets of treadmills in a single visit. So I break them up. I find that to be easier, and patients are quite understanding about that, I found.
That makes sense. And then the next question, is it necessary to test at 1 minute, or can you just test at 5 minutes for chronic exertional compartment syndrome?
Some people only test at 5 minutes. And I don't, I have nothing to say that that's the wrong way to do it, or that doing it at rest 1 and 5 is the right way. Some people will do a 5 minute and a 15 minute. Because again, at 15, it should be back down to resting pressure. And so the way I do it again is I do a resting 1 minute and 5, but I do know some people who do a resting in a 5 and a resting 5 and 15. And I don't think that there's anything that's going to say that that is one way is better than another. It is less pokes for the patient potentially if you just do a resting in a 5 because you do 2 rounds instead of 3. And obviously the less times you poke a hole in them, the less likely they are to create some type of complication. But again, my way of doing it is to do the to do the 3 tests. But I don't have any science that shows that it's better or worse than any other way. And again, if they're positive at 1, I don't get to the 5. So, you know, I do get patients that are only positive at the 5 minute though, because they went up high, just not quite high enough at 1 minute, and it didn't come down the way it was supposed to. But my feeling is that you have to carry out a test at least until 5 minutes, for sure, if it's stayed normal until that point.
Okay. Do you have time for 1 or 2 last questions?
Absolutely.
Okay. Do you have any thoughts on what system to use for testing, or ones that you used in the past, or the one that you use now, just for comparison, or
Well,
what you know?
Yeah, I mean, we always try to be very careful that we're not advertising for a particular company or something like that. There's the monitor device that I showed you is one of the new company that actually makes the device. It used to be Stryker Company. Used to make the handheld pressure device that most people used, but they actually stopped doing it. They stopped making the needles some time ago, and then traded that over to another company, and then stopped making the monitor itself. There are a couple companies out there. There's actually one where you can buy this little tiny device that you hook the needle directly to, and then on the other end you hook it to your syringe, and it's all right on the one syringe, a little tiny pressure measurement device. I haven't seen data on how accurate it is, but the one that you saw in the talk is the newer model of what I use. And I use a side port needle, and I actually have to poke them each time to get their measurement. I don't do an indwelling catheter. The very first time I tried to do this, I was a new attending physician at University of Pittsburgh. We had a gymnast with what we thought was exertional compartment syndrome only during floor exercise. And we took these split needles and we put the catheters in, and we take them to her leg, sent her out to do her floor routine, and she popped all 4 of them out. And we had to put 4 new ones in, and she did it again. And we just said, look, you know, the indwelling, forget it. We're just going to stick you with needles and get our answers that way. But I use the side port needle, but I do have to stick them every time. A lot of people like the indwelling one because they, again, they don't have to repeat the pokes, and they can get their measurements a lot more rapidly than I can. So it's a lot closer to that 1 minute and a lot closer to that 5 minutes. So it may be a more accurate way to do, but there is a cost associated with that my company won't take.
Okay. And then last question, if you have time for it.
Sure.
How effective is physical therapy for this, have you found?
It's not terribly effective. That I have found. I find that most people who have this and try physical therapy, you're going to be around 15 to 20% of people are going to get better and not need surgery. So it's about 1 in 6, 1 in 7. So it's not great. It's still worth a try. Most people, it's only during certain activities too. So I kind of joke with my patients. I'm a big guy. I'm only 6'2", but I weigh about 2 1/4. I run, but I run like a herd of elephants. You can hear me coming down the street from a mile away. But I run 5 miles a day, 3 times a week. If someone told me that I had exertional compartment syndrome and the only way I could keep running was to have a fasciotomy, I'd quit running. And so, you know, it's when I'd find something, I'd make more time and I'd find something else to do. And so, again, the one thing is, do you love what you're doing enough to have surgery for it? Because if the answer is no, I really don't, then try to find them some other avenue for exercise where they don't have to have a surgery. Because just because they have it during running doesn't mean they want to be a runner or involved in that kind of activity. Now, most people are coming in because they do want that, and they're willing to have the surgery to get it done. Yeah, it's not terribly effective. But again, I think it's still worth a try, because anything short of taking the risk of surgery, I think, is reasonable. And you're not delaying things for a terribly long time either, I don't think.
Okay. Well, I think that we'll do it. Thank you so much, Jim, for the great lecture and all the questions that you answered. And thank you everyone for tuning in today. It was a great lecture and great attendance. And we do have a lecture coming up next week. It will be on mental health during COVID-19 next Tuesday at 4 p.m. Eastern Time. Ashwin Rao will be the lecturer and our moderator will be Samir Dixit. So thank you, everyone. Have a great week. Hope your Thanksgivings were all nice, even though they were probably smaller.
Thank you, Heather.
Thank you.
Thanks, Andy.